तो मतलब अगर हम 10 केस जिसको एक्चुअली में एपिलेप्सी है इधर इटली की तरह अगर बीजेसी इटली सारा वही इधर इटली मतलब वो पूछते हैं कि दो ये दो जो बहुत कॉमन किया जाता है मतलब स्टैंड में से तो ये मैं तो मान के अगर पॉजिटिव में डेवलपमेंट साइड
अगर किसी का आ गया तो मतलब है
अगर जो वो ढूंढ रहा है अगर वही मिल गया वही होगा वो इधर ही होगा।
वीडियो अगर आपका है और आप कुछ होगी तो स्पेसिफिसिटी हाई हो सकती है। मान लो आपको जैसे हम वीडियो ईजी करते हैं ओवरनाइट ईजी करते हैं उसमें अगर आपने एक सीजर कैप्चर कर दिया तो देन इट इज मतलब दैट इज स्पेसिफिसिटी हाई हो सकती है।
Good morning, everyone. My topic for today's presentation is diagnosing epilepsy, and my moderator is Dr. Sumit Mehta, sir. This is an overview of all of the topics that we will be going through today. First, we will talk about what is epilepsy, the symptoms of epilepsy, and the differential diagnosis. And finally, we will talk a little bit about the investigations which we can do for diagnosing epilepsy. Now, what is epilepsy? Epileptic seizures are sudden involuntary behavioral events associated with excessive or hypersynchronous electrical discharges in the brain. The seizure itself is known as the ictus. The interictal period refers to the period between the post-ictal abnormalities and the next ictus, and the periictal period refers to the period just before or after the ictus and is applied when there is insufficient information to know when the ictus ends or begins. Epileptic seizures, they can have a genetic basis or can be caused by an acquired insult, such as trauma, stroke, inflammation, or neoplasm. Now, epilepsy is the recurrent tendency to seize, and status epilepticus is prolonged or repetitive seizures without intervening recovery. Now, this is a table showing the classification of seizures based on the 2017 International League Against Epilepsy classification of seizure types. We can have focal onset seizures, which can be further described as having intact or impaired awareness, motor or non-motor onset, or they may evolve from focal to bilateral tonic-clonic. Then we can have generalized onset, which can be motor or non-motor. Motor includes tonic-clonic, and other motor are like atonic or myoclonic, and non-motor are your absent seizures. Then we can have unknown onset, which include motor, non-motor, or unclassified. Now we talk about the symptoms of epilepsy and the differential diagnosis. Now, whenever a patient presents with an event that has been thought to possibly be due to an epileptic seizure, it is the history from the patient and any witnesses to the attack that is the most crucial part of evaluation. Complete reliance should never be placed on the history related by the patient alone, because often he or she will only have a limited recall of events and can only summarize what was passed on by witnesses. A videotape record made on a handheld video recorder often provides invaluable objective data on the nature and sequence of events in a seizure. Now, the main categories of episodic symptoms that may be caused by epilepsy include loss of awareness, generalized convulsive movements, drop attacks, transient focal motor attacks, transient focal sensory attacks, facial muscle and eye movements, psychic experiences, aggressive or vocal outbursts, episodic phenomena in sleep, and prolonged confusional or fugue states. Now, first we will talk about loss of awareness. The three main causes of loss of awareness can be syncope, epilepsy, and cardiac arrhythmias. Transient cerebral ischemia due to vascular abnormalities is less common, and microsleeps, which are very short daytime naps, may occur with any cause of severe sleep deprivation or disruption. And other causes of diagnostic confusion are much rarer and include hypoglycemia or other intermittent metabolic disorders, structural anomalies of the skull base affecting the brainstem, and lesions affecting the CSF circulation. Now, first we will talk about syncope. Now, the key features of syncopal attacks are there will be evidence of precipitant factors. There will be lightheadedness, there may be nausea, there may be pallor, ringing in the ears, bilateral loss of vision, some twitching collapse, some twitching movements may occur. There will be rapid recovery when the patient will be supine, and there may be sweating or subsequent flushing. Precipitant factors may be like the patient who suddenly stood up quickly, prolonged standing, or any emotional scenes may cause syncope. Now, irregular and myoclonic jerking is common in syncope and is often mistaken for epilepsy. However, such jerking will be sporadic, uncoordinated, lasts for a few seconds, and is not associated with tonic stiffening. Second differential of loss of awareness is epilepsy. Now, several types of seizures may present with loss of awareness as the sole reported manifestation, which include absence seizures, complex partial seizures, tonic seizures, or atonic seizures. Third cause may be cardiac disorders, like transient cardiac arrhythmias, may cause episodes of abrupt loss of awareness, mimicking epileptic seizures. Now, there are often prodromal features which are similar to those seen with simple syncope, as well as palpitations, chest pain, shortness of breath, or other features of cardiovascular insufficiency. Occasionally, cardiac disorders may present with impaired awareness and focal neurological features, presumably due to critical hypoperfusion of specific brain regions. Now, patients with unexplained blackouts will require a detailed cardiac evaluation with ECG, 24-hour ECG tape, chest radiograph, and an echocardiogram, especially if there are no abnormal neurological features. Now we talk about non-epileptic attack disorder, which was earlier called as Now we talk about non-epileptic attack disorder, which was earlier called as pseudo-seizures. Now, this is a table which shows how do we differentiate if it was an epileptic seizure or it was a non-epileptic attack disorder. A precipitating cause is rare in an epileptic attack, while in non-epileptic attack disorder, it will be common, emotional, and stress-related. Epileptic attacks are usually common when the patient is alone or asleep, but it will be less reported in non-epileptic attack disorder. The onset is usually short in epileptic attack, while in non-epileptic attack disorder, it may be short or over several minutes. The aura in epileptic attack is various and usually stereotyped, while in non-epileptic attack disorder, there will be fear, panic, and altered mental state. The speech in an epileptic attack, we can have a cry, grunt at onset, muttering, words and automatisms. While in non-epileptic attack disorder, it will be semi-voluntary and often unintelligible. The movement in epileptic attack will be atonic, tonic. If clonic, synchronous, small amplitude jerks will be present. While in non-epileptic attack disorder, it will be asynchronous flailing of limbs, pelvic thrusting, and opisthotonus. Injury in an epileptic attack, there may be tongue biting, fall, and directed violence is rare. While in non-epileptic attack disorder, the patient may bite tongue, cheeks, lips, hands, throw self to ground. Directed violence is not uncommon. There will be complete loss in generalized tonic-clonic epileptic attack, and it may be incomplete and complex partial. But in non-epileptic attack disorder, the consciousness will be variable. It will be often inconsistent with the seizure type. The response to stimulation in an epileptic attack, there will be none. The patient will not respond in generalized tonic-clonic. He may respond in complex partial and post-ictally. While in non-epileptic attack disorder, the patient often reacts and this may terminate the episode. Incontinence is common in epileptic attack. It is usually uncommon in non-epileptic attack disorder. The duration of an epileptic attack is usually of a few minutes. And in non-epileptic attack disorder, it is also usually for a few minutes only, but in some cases may be prolonged. The recovery.
Stereotype has that मतलब हुआ?
Sir, stereotypes. So stereotypes are your
stereotype. Stereotype it is same. Okay, in all the seizures, it's not changing. Different. Stereotypy मतलब हमें same over and over. So if somebody has one aura, then it repeats itself. Yes, so you'll have the same stereotype. It's very important in diagnosing the aura. Sometimes if somebody is having anxiety and then this, you will always have those symptoms in that neurological order of that patterns.
The recovery in an epileptic attack will depend on the seizure time, and usually it's of a few minutes and there is more prolonged confusion. While in a non-epileptic attack, it may be rapid or it may also be very prolonged. Now, this is a table which shows the difference between malingered seizures versus non-malingered, non-epileptic seizures. Now, in malingered seizures, the preceding ictus, it is usually more common in men. We will be less likely to obtain prior abuse history, less likely to obtain prior psychiatric history. There will be an evident secondary gain. There will be no clear emotional precipitants. Seizures are not suggestible. While in a non-malingered, non-epileptic seizures, there will be a marked female predominance. There may be a prior history of physical or sexual abuse. There will be a prior psychiatric history, no clear secondary gain, frequent emotional precipitants, and seizures may be easily suggested. Now, during ictus in a malingered seizures, you will usually be under volitional control. There will be conscious awareness of seizures. The patient will not be able to maintain the deficits over time, and errors in seizure behavior are likely to be major distortions. While in non-epileptic, non-malingered seizures, they are not under the volitional control. There will be subconscious awareness of seizures, and the patient will be able to maintain the deficits over time. Now, errors in seizure behavior, they are likely to be omissions, perseverations, and near misses. After ictus in a malingered seizure, the patient will be angry, anxious on confrontation, with a lack of evidence for epileptic seizures, and he will also be uncooperative, including circumstantial and evasive answers, and may leave against medical advice. While in a non-malingered, non-epileptic seizures, the patient will be indifferent, detached. He will be cooperative with the workup, but answers may be devoid of content. Now, the most useful test will be to record an attack with simultaneous EEG and video, but this depends on the frequency and reproducibility. Videotapes of seizures obtained using a handheld video recorder may provide useful diagnostic data, and it can be combined with 24-hour ambulatory EEG recordings. Now, some patients may have both epileptic and non-epileptic attacks, but usually one of these types clearly predominates. Now, the second key feature is generalized convulsive disorders. The first differential is epilepsy. Now, classically in a convulsion, there will be a cry, generalized stiffness of body and limbs, followed by rhythmic jerking of all four limbs, associated with loss of awareness, eyes staring blankly, tongue biting, and urinary incontinence. The generalized convulsive movements usually last for a minute or so, and as the attack proceeds, the jerking slows in frequency and increases in amplitude. There is often cyanosis, and afterwards irregular breathing, followed by confusion, headache, and sleepiness. The second differential can be syncope with secondary jerking movements, which we have already discussed earlier. This jerking will be usually irregular, short-lived, and it does not have a pattern which evolves in the same way as do the convulsive movements of a tonic-clonic seizure. Third is primary cardiac or respiratory abnormalities presenting with secondary anoxic seizures. Now, this will be especially important when the preceding history is uncertain. For example, attacks which are occurring in sleep, or when no neurological abnormalities are evident on examination or investigation. And non-epileptic attack disorder. Now, they may be especially difficult to differentiate from complex partial seizures of frontal lobe origin, which can present with very bizarre motor attacks with some retained awareness and with quick recovery, and which may not be associated with scalp EEG changes. The third symptom is drop attacks. Now, the causes of drop attacks, it is first epilepsy. Second, there may be a cardiovascular cause like syncope, Stokes-Adams attacks, and transient brainstem ischemia. Then there may also be movement disorders, which include hyperkiplexia, Steele-Richardson-Ozwecki syndrome, Parkinson's disease, multi-system atrophy, paroxysmal kinesiogenic choreoathetosis, and subcortical myoclonus. Other causes of drop attacks may be brainstem, spinal or lower limb abnormalities, third ventricle tumors, vestibular, cataplexy, metabolic like periodic hypokalemia, non-epileptic attack disorder, and idiopathic drop attacks. The next key feature is epilepsy may include transient focal motor attacks. The commonest cause of transient focal motor attacks is epilepsy. In children and adolescents, consideration should be given to tics and associated syndromes. Paroxysmal movement disorders are rare, although unilateral paroxysmal kinesiogenic movements can be seen occasionally, for example, with basal ganglia ischemia. And tonic spasms of multiple sclerosis, they are usually seen once other features of the illness have become apparent, but may be a presenting feature. Now, transient focal sensory attacks, it may be divided into somatosensory attacks and transient vestibular symptoms. Now, in epileptic seizures, which involve the primary sensory cortex, they are less common than motor seizures, and may have similar modes of propagation to Jacksonian motor seizures with spreading paresthesia. Seizures involving the second sensory area or mesial frontal cortex may cause sensory illusions, but usually have less well-defined qualitative and anatomical features. Transient sensory phenomena may also be seen in peripheral nerve compression or other abnormalities of the ascending sensory pathway, hyperventilation or panic attacks, and in transient ischemic attacks. Second is transient vestibular symptoms. Acute attacks of vertigo may occasionally be due to a seizure in parietal or temporal lobe. In these cases, there are generally associated features that point to cerebral involvement, such as focal somatosensory symptoms, deja vu, or disordered perception. Peripheral vestibular disease, however, is a much more common cause and may give rise to paroxysmal rotational vertigo and perception of linear motion. Next is facial muscle and eye movements. Changes in facial movements may occur in various neurological conditions, including focal motor seizures, complex partial seizures with automatisms like chewing, lip smacking, or grimacing, tics, dystonias, or other paroxysmal movement disorders, especially drug-induced dyskinesias and hemifacial spasm, as well as psychological disorders. Intermittent eye deviation may be a particular problem in patients with neurological abnormalities due to nystagmus or other problems with eye movement control. Focal motor seizures because twitching of one side of the face, although it should be noted that this may occasionally be bilateral due to the bilateral representation of the face in the primary motor cortex that may be restricted to specific areas and maybe only over the eyes or perioda. And eye deviation is often seen with seizures arising in frontal parietal or occipital cortex. Complex partial seizures may cause automatisms with lip smacking, chewing, swallowing, sniffing, or grimacing, with amnesia and impaired awareness. Hemifacial spasm typically presents in the elderly or middle-aged with clusters of attacks that initially involve the eye, but subsequently spread to rest of that side of the face. Bruxism may occur either during the day or in sleep, especially in children with mental retardation, and episodes are usually more prolonged than with the automatisms of complex partial seizures, and there are no associated features to suggest an epileptic basis. Next feature can be psychic experiences. Partial seizures of temporal lobe origin are especially likely to manifest themselves with aura involving psychic phenomena. The most common are fear, deja vu, memory flashbacks, visual, olfactory, or auditory hallucinations. Other manifestations include altered perception of the environment with a distancing from reality or change in size or shape of objects, altered language function, and emotions such as sadness, elation, and sexual arousal. Migrainous psychic phenomena may involve an initial heightening of awareness, and the principal features are usually visual illusions that may be elemental or complex. The time course is usually more prolonged than with partial seizures, and there are associated features of a pounding headache, photophobia, and nausea or vomiting. Panic attacks are usually associated with feelings of fear and anxiety. Hyperventilation may lead to dizziness and lightheadedness, and there are often unpleasant abdominal sensations similar to the epigastric aura of partial seizures. Now, non-epileptic attack disorder, it may also be associated with reports of hallucinations and illusions, and these often evolve out of previous questioning by members of the medical profession. Initially, the symptoms may seem plausible, but they should be suspected if they are florid and multiple in type, like all auditory, olfactory, and visual at different times, with evolving stories or patterns of expression. Next is aggressive or vocal outbursts. These are rarely epileptic in nature if they occur in isolation, and they are especially common in adults and children with mental retardation. In this setting, there may be an organic brain disease, which could lower the overall seizure threshold. Now, the features against there being an epileptic basis to an aggressive attack are that there is an absence of a prior history of epilepsy with automatisms. There may be premeditation and evidence of planning or preparation. There may be directed violence. We will find evidence of complicated and organized activity during the episode. There will be recall of events during the episode. Witness accounts will not be indicative of a disturbance of consciousness, and there will be subsequent attempts at escape or concealment of evidence. Now, episodic phenomena in sleep. It may be because of normal physiological activity, like whole body jerks or hypnic jerks, fragmentary myoclonus, and periodic movements of sleep. Epilepsy, which may frontal lobe seizures may cause episodic phenomena in sleep. Other partial epilepsy and generalized convulsions may also cause this. Sleep disorders include pathological fragmentary myoclonus, restless leg syndrome, non-REM parasomnias, REM parasomnias, and sleep apnea. Next is prolonged confusion of fugue states after generalized convulsions, or less often complex partial seizures. There may be confusion lasting for many minutes, but rarely more than an hour. Such episodes only present diagnostic difficulty if the initial seizure is unwitnessed or forgotten. Nevertheless, epileptic states can last for longer periods of time, as can other types of cerebral disorder, and the differential diagnosis of prolonged epileptic confusional states should include acute encephalopathy, non-convulsive status epilepticus, transient global amnesia, intermittent psychosis, and hysterical fugue. Now we will talk a little bit about the lab investigations. Now, seizure and epilepsy are clinical diagnoses. Additional tests can help identify provocative factors and diagnose seizure syndromes. In addition to routine lab data and toxicology screens used to exclude reactive seizures, several neurodiagnostic tests are useful in the assessment of epilepsy. SCAD EEG is the most widely used confirmatory test for seizures. However, sensitivity ranges from 29 to 55%. Single routine EEGs are frequently normal and must be repeated, particularly with provocative maneuvers such as photic stimulation, hyperventilation, and sleep deprivation. Occasionally, video EEG telemetry for an extended period of time is necessary to characterize spells of unknown etiology, for localization of seizure focus, and for classification of seizure in a patient with known epilepsy. Inpatient epilepsy monitoring units, they are very helpful in distinguishing epilepsy from PNES. Neuroimaging procedures such as CT and MRI can more precisely visualize the seizure focus or even mesial temporal sclerosis. And PET scans may show inter-ictal hypometabolism around the temporal seizure focus and are also useful in pre-surgical assessment of medically intractable seizure patients. These are my references.
Diagnosing epilepsy, but we didn't consider because these are under investigation. The point is, we want in this scenario, what can be the various presentation of various cases and how they are from other differential diagnosis. Specifically, see, any neurological or psychological phenomena can be in this. Almost all psychological symptoms or neurological symptoms. Many part of it is we know particular presentation can be part of season and which other disorder, then we will be able to more in the view of the other diagnosis. Now how it's looked at the and it's again a clinical diagnosis for the without doing this and without doing other diagnosis. Did you find anywhere how like role of like after